Hi guys, welcome back. I shall now be explaining to you regarding image-based questions related to nephrology. The first one talks about urine crystals that were found in the urine of a patient who had suffered from 2 episodes of flank pain radiating to the umbilicus in last 3 months. So we are talking about renal colic, and then we are talking about an individual who is having this following dumbbell-shaped crystals when it comes to urine microscopic examination. I have explained to you that calcium oxalate can actually exist in two forms. One of the forms would be having a typical envelope-shaped crystals, and the second one, the monohydrate form, can be having a dumbbell shape as well. So the bottom line is that this particular guy with renal colic is having the etiology of stones as being calcium oxalate. He says, which of the following are correct about this particular condition? A says perform 24-hour urinary calcium levels. I have explained in the routine lectures that one of the leading causes of calcium oxalate stones is idiopathic hypercalciuria. This particular chap, he could be having defective handling of calcium by the kidneys. Apart from these, conditions could be like enteric oxaluria, where the handling of oxalate by the body is defective. But the number one cause is idiopathic hypercalciuria, so 24-hour urinary calcium makes sense. Restrict salt intake. Yes, for people who are having calcium oxalate stones, I would specially tell them not to restrict calcium in the diet. A lot of these people stop avoiding, rather they avoid milk, cheese, dairy products primarily because they've read on these so-called medical websites which are not handled by doctors like you and me saying that avoid dairy products because they contain calcium. Studies have shown that if these patients will avoid calcium-based products, the chances of development of calcium stones will rather increase. So what is to be restricted in these patients are two things. One, I would like this guy to restrict the intake of sodium, and second, I would not like him to eat oxalate-rich vegetables like spinach. So low oxalate diet also makes sense. Low urinary pH predisposes to recurrence. I want to highlight the fact that calcium oxalate stones per se are pH independent. I have highlighted this in the discussion of stones per se, that all stones in the kidney are dependent on the pH values, but pH independent is calcium oxalate. The correct answer to this particular question is option number 1, and they'll deliberately make this question longish by actually having 2 steps that you will have to select multiple correct options in this case. The answer is anyway straightforward one in this one. The shapes of crystals I've already highlighted. It could be envelope shaped crystals, as you can make up in this case with respect to calcium oxalate, or monohydrate having a dumbbell shape. Uric acid crystals, guys, they do not have any particular shape. They can be rosette, they can be needle shaped, they can be irregular shaped, they could be quadrilateral, pentagon. Really does not matter because they're soft. So please do not answer any particular shape for the softest kidney stone, that is uric stones. But Stewart stones are obviously going to be coffin lid appearance, and they are the ones which are going to be related to Proteus mirabilis, which is a urea splitter organism. When it comes to cystine stones, they would be classically hexagonal in shape. So this is taught in microbiology as well as in pathology. Then even the surgeon would have talked about it. But I just wanted to highlight how can you prevent these stones from occurring. And additional information from my side is I can write thiazide diuretics to this particular person to reduce the incidence of stones in future life of this chap. Moving to the second one, he will give you angiogram in a hypertension patient. First thought process of mine will be when I see a renal angiogram and hypertension, I will think it is renal artery stenosis, and yes, it is. If you look at the caliber of the artery, it definitely looks defective. Now let's look at what is the problem here. So you will notice, and I will use a finer pen to highlight this here, that if you look at the caliber of the blood vessel, there appear to be some saculations present here. And this saccular appearance is what is present with respect to fibromuscular dysplasia. So most of the questions that you will get, especially with respect to a renal angiogram or renal artery stenosis, see, either you have to pick up atherosclerosis or you have to pick up the classical fibromuscular dysplasia where these sacculations can be present. If it was only ostial narrowing, if the arteries were a narrow caliber and there was relatively ostial narrowing, the contrast flow will be lesser, but the surface of the artery will actually look relatively regular. So that is how I have ruled out atherosclerosis, that atherosclerosis per se causes mainly ostial narrowing. The remaining caliber of the artery looks okay. Takayasu's arteritis and non-specific arteritis, both of them again mean the same. So why can't C be the answer? Because then D can also not be the answer because both of them mean the same. And again, this would again be having a substantial ostial narrowing. See, in atherosclerosis, and Takayasu's arteritis, the fundamental difference is in atherosclerosis, the opening of the blood vessel will be narrow and even the lumen of the blood vessel, but it will be smooth lumen, but the lumen of the blood vessel will be narrow. Takayasu causes only osteal narrowing. So I am rephrasing my statement, guys. I am saying that per se, when it comes to Takayasu, it is only osteal narrowing. In atherosclerosis, it is a combination of osteal narrowing plus the whole artery narrowing also present. FMD, on the other hand, will be having a artery appearance in the form that I have highlighted before. The name is fibromuscular dysplasia. The irregular appearance of the blood vessel or the corrugated appearance can definitely be made up. The answer to question number 2 is A. In the third question, you can definitely make up polycystic kidneys, and because he's mentioning regarding a 25-year-old guy, so my clinical diagnosis right away on this question will be autosomal dominant polycystic kidney disease, and these are progressive condition where the cysts can even be having a bleeding contributing to flank pain. He is asking why would these patients die? Then the number one cause of death in these patients is not uremia. This is the kind of a question where I'm actually hunting for the answer. Where is it present? The correct answer is cardiovascular mortality, guys. I've highlighted both in chronic kidney disease as well as ADPKD. It is cardiovascular mortality which is the leading cause of death. So the answer in this case would be given as hypertension. I agree to the fact that in some older books it is given as uremia, but in Harrison 20th edition it is cardiovascular mortality which is the number one reason for death in these patients. It is uncontrolled hypertension or high renin hypertension which will be ultimately causing expiry of this patient. Question number 4 says a patient is scheduled for hemodialysis. You can see that there is a fistula between the radial artery and the cephalic vein, and we call it the seminobrestia fistula. You see the clean blood will flow into the cephalic vein subsequently. You can see that we are taking the blood from the fistula, sending it to the hemodialysis machine. Hemodialysis needs to be done 3 times per week. One session is approximately 4 hours, but the fistula that is connecting the radial artery and the cephalic vein is the one that is called as a seminobrestia fistula. Moving to the next one, he has given a micturating cystourethropy. Traditionally, when we see MCU image, we are always in a habit of answering vesicoureteric reflux. But in this case, I would like you to specially look at the appearance of the bladder. You can notice the irregular appearance of the bladder in this case, which is characteristically written either as pine tree bladder or rather a Christmas tree bladder. You see, when I say the word Christmas tree bladder, that is always a feature of neurogenic bladder. Why is it not vesicoureteric reflux? Because then the reflux, you can definitely see some contrast on one side, but not in the contralateral ureter. So VUR is unlikely, and moreover in VUR, the configuration of the bladder will be smooth. Bladder diverticula, well, to have 1 or 2 diverticula is fine, but to have such large number of small diverticula is really unlikely. So the classical description is that of neurogenic bladder only. Bladder outlet obstruction will cause trabeculated bladder, like somebody is having benign prostatic hyperplasia. The trabeculations can be seen from the inside on a cystoscopy and cannot be made up with help of a contrast. The correct answer to this question is option number beta. Another question has come up on autosomal dominant polycystic kidney disease, saying all are true about this condition shown, except the bottom line is that this condition is progressive. The cysts are gonna be continuously developing, so the GFR will progressively fall and the renin will increase. Option A says cysts at the junction of the distal tubule and the collecting duct. You see the cysts are present both in the cortex and the medulla, but if you read the histopathological domain of ADPKD, he will mention about cysts at the junction of the DCT and the CD. Spider leg deformity is an intravenous pyelography finding, and usually we avoid doing IVP in these patients because of risk of contrast-induced nephropathy. Anemia will definitely be seen because kidneys are getting affected. So these 3 options are looking okay, but if you look at the last statement, it says low renin. Now that's not possible. It is actually a high renin hypertension. There are only 2 examples of low renin hypertension that I have described in endocrinology before you. Let me just recap those 2 for you. Low renin hypertension has been discussed for Conn syndrome and for Liddle syndrome. One is excess of hormone, second is gain of function of the epithelial sodium channel. So option number D is definitely the correct answer for this multiple choice question, since it is wrongly saying the word low renin hypertension. Image based questions on kidney are relatively simpler because mostly they will ask you about cystic kidneys, then they can ask you about ciliopathies. I have talked about the specimens of ciliopathies in the ciliopathic specimen apart mainly. So I would definitely like you to go through the lecture of ciliopathy per se in the kidney, because that will help you revise all the tubular disorders that are discussed in pathology also. These are the details that I wanted to remember for this session. Thank you so much for hearing me out.